Most people hear Sjögren's and picture two things: dry eyes and dry mouth. And if that's genuinely all it ever did, we probably wouldn't need a channel like this one. But here's the truth: almost nobody tells patients clearly, in one place, all at once. Sjögren's is not a dry eyes disease that occasionally causes other problems. It's a systemic autoimmune disease that can reach into nearly every organ system in your body, and researchers have documented real, measurable involvement in roughly 20 distinct body parts, systems, and organs. Today I'm walking through all 20, with the actual warning signs for each one, because a lot of these get missed, dismissed, or blamed on something else for years before anyone connects them back to Sjögren's. Let's get into it. Before the list, I want to explain why this happens at all, because it's not random, and understanding the why makes the whole list click into place instead of feeling like a scary grab bag of unrelated symptoms. Sjögren's starts as an attack on your exocrine glands, the glands that produce moisture. Tears, saliva, that's the famous part. But your body has exocrine-style glandular tissue tucked into far more places than your eyes and mouth. Your pancreas has it. Your skin has it. Even structures deep in your digestive tract share some of that same tissue type. So when the immune system starts misfiring against moisture-producing tissue in general, it doesn't always politely stay confined to the two glands everyone associates with this disease. And separately, independent of the gland attack entirely, Sjögren's also involves broader immune dysregulation, antibodies, inflammatory signaling, occasional vasculitis, that can reach organs that have nothing to do with moisture production at all, like the kidneys, the nervous system, or the heart. Two different mechanisms, one disease, and a genuinely wide reach as a result. One more thing before we start, because I don't want anyone spiraling while I go through this list. Research consistently shows that only around 15% of Sjögren's patients develop what's classified as severe extraglandular disease. The vast majority of people with this condition live with the glandular symptoms, the dryness, the fatigue, without ever developing serious organ involvement. This list is about awareness, not prediction. Knowing the warning signs means you can catch something early if it happens, not that it's going to happen to you. I also want to be upfront about something else. This list pulls together findings from a wide range of clinical studies and patient education resources, and the honest reality of autoimmune research is that estimates vary quite a bit between studies, different patient populations, different countries, different diagnostic criteria used at the time. Where a range of numbers exists in the research, I'm going to give you the range rather than picking whichever single number sounds the most dramatic, because that's the more honest version of this story, even if it's slightly less tidy. Okay. 20 body parts. Let's go. Number 1. The salivary glands. This is the classic one, but the warning signs go well beyond just "my mouth feels dry." Watch for difficulty swallowing dry foods without water, a change in your sense of taste, frequent cavities appearing in teeth that never used to get them, and visibly swollen glands along your jawline or in front of your ears, which can come and go in flares. Number 2. The lacrimal glands and eyes. Beyond the obvious dry, gritty feeling, watch for a persistent burning sensation, light sensitivity, blurry vision that improves with blinking, and a stringy discharge in the corners of your eyes when you wake up. Left unmanaged long enough, chronic dryness can actually damage the surface of the cornea, so this one is worth taking seriously even when it feels like just dryness. Number 3. The thyroid. This connection surprises a lot of people. Autoimmune thyroid disease, especially Hashimoto's thyroiditis, shows up in a notably higher percentage of Sjögren's patients than in the general population. Some studies put co-occurring thyroid dysfunction as high as 30 to 45%. Warning signs include unexplained weight changes, feeling cold or hot when others around you don't, hair thinning, and a fatigue that feels different from your usual Sjögren's fatigue, heavier, more like your whole system slowed down. Number 4. The lungs. Sjögren's can cause dryness of the airways themselves, plus, less commonly, interstitial lung disease. Watch for a persistent dry cough that doesn't respond to normal cold or allergy remedies, shortness of breath with activities that never used to wind you, and recurring bronchitis that keeps coming back. These pulmonary changes show up in a meaningful minority of patients and are genuinely worth flagging to a doctor rather than writing off as seasonal. Number 5. The kidneys. This one is sneaky because kidney involvement in Sjögren's often causes no obvious symptoms until it's fairly established. When symptoms do appear, watch for excessive thirst that doesn't match your fluid intake, unusual muscle weakness, kidney stones showing up unexpectedly, or blood work that shows abnormal potassium levels. The most common pattern is something called renal tubular acidosis, which affects how your kidneys handle acid and electrolytes rather than filtering ability directly. Number 6. The liver. Sjögren's raises the risk of a couple of specific liver conditions, most notably primary biliary cholangitis, where the small bile ducts inside the liver get damaged. Mild liver involvement often causes zero symptoms and only shows up on routine blood work. When it does cause symptoms, the two big ones are persistent itchy skin with no rash to explain it, and yellowing of the skin or eyes, which is always worth an urgent conversation with a doctor regardless of the cause. Number 7. The pancreas. Less commonly discussed, but real. Watch for nausea or vomiting that seems to come out of nowhere, abdominal pain that radiates toward your back, unexplained loss of appetite, and pain that gets noticeably worse after eating. Autoimmune pancreatitis and other pancreas problems are less common than the eye and mouth symptoms, but they are a genuine part of the extraglandular picture. Number 8. The peripheral nerves. This is one of the most underrecognized parts of the entire disease, and I want to slow down here because it matters. Small fiber neuropathy, damage to the tiny nerve fibers responsible for temperature and pain sensation, has been documented in a meaningful percentage of Sjögren's patients, and here's the part that gets missed constantly. Neurologic symptoms can actually show up before the classic dry eye and dry mouth symptoms do. Watch for a burning or tingling pins and needles feeling in your hands or feet, a strange numbness that spreads in a stocking and glove pattern up your arms and legs, and pain that standard nerve tests come back normal for, because small fiber damage frequently doesn't show up on a routine nerve conduction study. If you've been told your nerve tests are normal while you're still in genuine pain, that doesn't necessarily mean nothing's wrong. It might mean the wrong type of nerve fiber was tested. Number 9. The brain and central nervous system. Less common than peripheral involvement, but documented. Watch for brain fog that goes beyond normal forgetfulness, trouble finding words, difficulty concentrating that interferes with work or conversation, along with headaches that are new or have changed character, and in rare cases, more serious neurological events involving vision or muscle weakness that need immediate medical attention. Number 10. The skin. Watch for dryness that goes beyond normal winter skin, unexplained hair thinning or loss, brittle nails that crack or split easily, and a specific kind of rash called purpura, small, reddish-purple spots, often on the lower legs, caused by inflammation in tiny blood vessels near the skin's surface. That particular rash is worth photographing and showing a doctor rather than just moisturizing and hoping it fades. Number 11. The blood vessels themselves. This overlaps with the skin finding above but deserves its own mention, because vascular involvement in Sjögren's most commonly shows up as Raynaud's phenomenon, fingers or toes that turn white or bluish and go numb in response to cold or stress, then flush red and throb as circulation returns. It's uncomfortable, sometimes painful, and worth mentioning to your rheumatologist even if it feels like a separate, unrelated quirk of your circulation. Number 12. The heart. Genuinely rare, but real cases exist of pericardial effusion, fluid building up around the heart, and even rarer cases of inflammation of the heart muscle itself. Watch for chest discomfort that's new, shortness of breath that doesn't match your activity level, or a heartbeat that feels irregular, too fast, or too slow. These are rare enough that they shouldn't be a source of daily worry, but they are serious enough that any of those symptoms deserve prompt medical attention regardless of the underlying cause. Number 13. The blood itself. Routine blood work in Sjögren's patients not uncommonly turns up low counts of red blood cells, white blood cells, or platelets. On their own, these often cause no symptoms and get caught purely on labs. When they do cause symptoms, watch for unusual fatigue beyond your baseline, unexplained bruising, or getting sick more often than usual. Number 14. The lymphatic system and lymph nodes. This is the one that deserves real attention, not panic, but real attention. Sjögren's carries a documented increased risk of lymphoma compared to the general population. Estimates in the research range widely depending on the study, but consistently land well above baseline risk. Warning signs worth knowing include persistently swollen lymph nodes that don't go away after a couple of weeks, swelling of the salivary or parotid glands that's new or one-sided rather than the usual flare pattern, unexplained weight loss, drenching night sweats, and a low complement level on blood work, which some studies have flagged as a risk marker. I want to be clear, the overwhelming majority of Sjögren's patients never develop lymphoma. But knowing these specific warning signs, rather than vague ones, is exactly the kind of thing that leads to early catches instead of late ones. Number 15. The digestive tract, beyond just the mouth. Watch for heartburn or acid reflux that's worse than it used to be, food feeling like it gets stuck partway down when you swallow, persistent bloating, and alternating constipation and diarrhea. Reduced saliva actually plays a direct role here, since saliva helps clear acid out of your esophagus, so less saliva can mean worse reflux even without anything else changing. Number 16. The bladder. Less commonly discussed, but a real pattern in Sjögren's called interstitial cystitis, chronic bladder inflammation not caused by infection. Watch for needing to urinate frequently and urgently, discomfort or pain in the pelvic region, and waking up multiple times a night specifically to urinate, separate from just drinking water before bed for dry mouth. Number 17. The reproductive organs. Vaginal dryness is common and often goes unspoken about, causing discomfort or pain during intimacy. In men, similar dryness can affect comfort as well. This one gets missed constantly simply because it's an uncomfortable topic to bring up, but it's a legitimate, treatable extraglandular symptom, not something to just quietly live with. Number 18. The muscles and joints. Watch for joint pain and stiffness, especially notable first thing in the morning, that improves somewhat as the day goes on, along with muscle aches that don't match your activity level. In some patients this overlaps with a separate diagnosis like rheumatoid arthritis, so persistent joint symptoms are worth a dedicated conversation with your rheumatologist rather than assuming it's just part of Sjögren's automatically. Number 19. The ears, nose, and throat. Watch for a persistently dry, scratchy throat, a chronic dry cough separate from any lung involvement, sinus dryness leading to nosebleeds or crusting, and occasionally hearing changes, since the same mucous membranes involved elsewhere in the body extend into this region too. Number 20. The voice and vocal cords. Often lumped in with lung symptoms, but distinct enough to call out on its own. Watch for hoarseness that lingers for weeks, a voice that tires out faster than it used to during a normal conversation or workday, and a persistent need to clear your throat that isn't tied to allergies or a cold. So that's the list. 20 documented areas, real warning signs for each, straight from the clinical literature. Before we get to what to actually do with this, I want to talk for a minute about why so many of these get missed in the first place, because understanding the why might be the most useful part of this entire video. Part of it is structural. Most people's path to a Sjögren's diagnosis starts with an eye doctor or a dentist noticing dryness, then a referral to a rheumatologist. That means the specialists most likely to catch this disease early are, understandably, focused on eyes and mouths. That's their expertise, that's what they're trained to screen for. A rheumatologist eventually takes over broader management, but by the time that handoff happens, patients have often already learned, consciously or not, to think of Sjögren's as the dry eye and dry mouth disease. So when a new symptom shows up somewhere else, tingling fingers, a weird cough, unexplained fatigue that's different from the usual kind, the pattern matching that would connect it back to Sjögren's just doesn't happen. Not because anyone's careless. Because nobody ever drew the full map for that patient in the first place. Part of it is also just how medicine tends to specialize. A gastroenterologist treating your reflux isn't necessarily thinking about your rheumatologic history while they're focused on your esophagus. A dermatologist looking at a rash isn't automatically cross-referencing it against autoimmune blood work from a different department. Every individual doctor along the way is doing their job well, looking at their piece of the puzzle carefully, but the person best positioned to see the whole puzzle is you, the patient, because you're the only one in the room for every single appointment. That's honestly a big part of why I make videos like this one. Not to replace your doctors. To help you become a better narrator of your own story across all of them. And part of it, honestly, is that a lot of these symptoms are individually easy to explain away. Everybody gets tired sometimes. Everybody's had a weird ache that went away on its own. Everybody's dealt with a stretch of bad sleep or a stomach that felt off for a few days. When you already have a chronic illness, there's a very real, very human tendency to file new discomfort under probably just part of having Sjögren's, or probably just getting older rather than flagging it as something worth a dedicated conversation. That instinct isn't wrong most of the time, most new aches really are nothing. But it means that genuinely important signals can get lost in the noise of everyday chronic illness life, which is exactly why having a specific list like this one, rather than a vague listen to your body, tends to actually help. Now, Because I always want to leave you with something useful rather than just something alarming, let's talk about what to actually do with all of this. The single most useful thing you can do with this list is not memorize it and start scanning your body for every possible symptom every single day. That's not helpful, and honestly, that kind of hypervigilance can become its own quiet source of stress. The useful version of this list is much simpler. Keep it in the back of your mind, and if something new and persistent shows up, something that doesn't resolve in a couple of weeks, something that feels different from your usual Sjögren's baseline, mention it to your rheumatologist specifically, by name, rather than assuming it's unrelated or too small to bring up. A huge number of extraglandular symptoms get missed for years simply because patients assume dry eyes and dry mouth are the whole story, so a new, unrelated feeling symptom doesn't get connected back to the same underlying disease. One practical tool that genuinely helps here: keep a simple running note, on your phone or on paper, of new or changed symptoms with a rough date attached. Not a detailed medical journal, nothing that becomes its own chore, just a line or two whenever something new shows up. Started noticing tingling in my left foot, mid-March. Throat's been scratchy for about 3 weeks now, not tied to a cold. That kind of note does two things. First, it turns a vague memory, I think this has been going on for a while, into an actual timeline you can hand your doctor, which makes a real difference in how quickly a pattern gets recognized. Second, it takes the mental load off you. You don't have to hold every symptom in your head, worrying whether it's worth mentioning. You just write it down and let your next appointment sort out what matters. Let's clear up a couple of things before the comment section does it for me. Myth: if I have Sjögren's, I'm eventually going to develop most or all of these. Reality: absolutely not, and I want to be very direct about that. Research consistently shows severe extraglandular involvement in only a minority of patients, commonly cited around 15% for the more serious systemic complications. Most people with Sjögren's live their whole lives with glandular symptoms and manageable fatigue, full stop. This list exists so the minority who do develop something can catch it early, not to suggest it's coming for everyone. Myth: if my rheumatologist hasn't mentioned organ involvement, they must not be taking it seriously. Reality: usually the opposite is true. Good Sjögren's care typically includes periodic blood work specifically designed to monitor for early signs of exactly the kind of extraglandular involvement we just covered: kidney function, liver enzymes, blood counts, complement levels. If your doctor is ordering that kind of routine monitoring, that's them actively watching for this stuff quietly in the background, not ignoring it. Myth: any new symptom means it's definitely Sjögren's spreading to a new organ. Reality: also not true, and genuinely important to say. Having Sjögren's doesn't mean every ache, twinge, or new symptom is automatically explained by it. Plenty of new symptoms in a person with Sjögren's turn out to be completely unrelated: a separate condition, a medication side effect, ordinary aging. The goal of this list isn't to make you attribute everything to Sjögren's. It's to help you recognize the specific patterns worth flagging, so you can have a focused, useful conversation with your doctor instead of either ignoring something important or panicking over something unrelated. Let's rapid fire a few questions I know are on your mind right now. Which of these 20 is the most common? By a wide margin, joint pain and fatigue-adjacent symptoms are the most commonly reported extraglandular issues, followed by peripheral nerve symptoms and mild thyroid involvement. Severe kidney, liver, lung, or heart involvement sits much further down the frequency list, which is genuinely reassuring context to hold on to. Should I ask for a full-body workup covering all 20 of these? Not necessarily all at once, and probably not without your rheumatologist guiding it. The more practical approach is routine, periodic blood work that screens for the more common and more monitorable issues: kidney function, liver enzymes, blood counts, thyroid levels, with follow-up on any specific organ only if you're actually having symptoms pointing that direction. I have some of these symptoms and haven't mentioned them to my doctor. Should I be worried I waited too long? No. Genuinely, no. Bring it up at your next appointment, plainly and specifically, and let your doctor take it from there. Chronic illness management is rarely about one dramatic moment where waiting made everything worse. It's much more often just, the sooner something's on your doctor's radar, the sooner it can actually be evaluated and, if needed, addressed. Does having more of these symptoms mean my Sjögren's is more severe? Not necessarily in a simple, linear way. Disease presentation in Sjögren's varies enormously between individuals. Some people have significant glandular symptoms with minimal extraglandular involvement, others have the reverse. It's genuinely not a scoreboard where more symptoms automatically means worse disease. Should I bring a printed version of this list to my next appointment? Honestly, that's not a bad idea, and I mean that sincerely rather than as a throwaway line. Doctors are human, appointments are short, and it's easy to forget half of what you meant to mention the second you sit down in that chair. Having something concrete, even just a few bullet points of new or changed things I've noticed pulled from your own tracking notes, tends to make appointments more productive for everyone in the room, not less. Here's what I actually want you to walk away with. Sjögren's asks a lot of the people who live with it, physically, and honestly, emotionally too, especially when symptoms show up in places nobody warned you about and you're left wondering if it's connected or if you're imagining things. You're not imagining things. This disease genuinely does reach further than most people are ever told when they are handed the diagnosis. But reaching further doesn't mean it reaches everywhere, in everyone, all the time. Knowing the map, knowing what to watch for and where, isn't about living in fear of your own body. It's about being equipped, the same way you'd want a map of any unfamiliar territory before you set out into it. I think a lot about the gap between what patients are told at diagnosis and what patients actually end up needing to know a year, 5 years, 10 years into living with a disease like this. That gap is where a lot of unnecessary fear lives, not because the truth is scarier than the vague version, but because an unmapped territory is always scarier than a mapped one, even when the mapped one has some difficult terrain in it. My hope with a video like this isn't to hand you something to worry about. It's to hand you something to recognize, calmly, if it ever shows up. The difference between those two things is bigger than it sounds. If this helped you understand your own symptoms a little better, or connected a dot you'd never connected before, share it with someone in your life managing this too. A support group, a family member, anyone who's ever been told it's probably nothing about a symptom that turned out to be very much something. That's exactly the gap this channel exists to fill. And if you want a deeper breakdown of any single one of these 20, the neuropathy piece especially seems to come up a lot in the comments. Tell me which one, and that's exactly where I'll go next. Take care of yourself, and take every part of your body seriously, not just the two everyone else remembers to ask about. I'll see you in the next one.